if you can't find it, I can just do it. I decided to bring a couple of actual situations and just to kind of, there we go, just even go up above there, right there. Yeah, okay. Just to kind of get your ideas about how you would handle a couple of things. So the first individual is a 79-year-old man who is a Vietnam veteran who developed multiple myeloma a couple of years ago. And based on what we were talking about earlier, this individual did have pretty high risk multiple myeloma, and also, though, has some important other medical problems. And in this case, this individual has heart failure that has been managed, although pretty successfully. He's a very active individual. He actually runs a scrapping business, and he wants to keep on scrapping. But he got treated initially because of his kidney failure with some drugs that we think are okay if your kidneys aren't working well. In this case, it was cyclophosphamide, bortezomib, and dexamethasone, Cybor-D. And he got switched over to bortezomib Revdex. And now he's back in about a year with some very pretty significant back pain that showed up and hip pain in a month. And to make a long story short, we figured out he now has myeloma that's coming back. And I guess in this situation, older individual, high-risk myeloma, some important medical problems. What might be the approach you would take in an individual like that?
Well, first, my microphone doesn't work, so there. I'm kidding. Well, first I want to say I love the DJ thing. I'm gonna steal. Totally gonna steal the DJ and like coming up with I just love that. Second thing, what I think is so I'm assuming this happened pre-DARA.
This individual has not had that.
Okay, and so a couple kind of important things is that the high-risk cytogenetics and the amplification of chromosome 1, which is, a really high-risk cytogenetic issue. And his creatinine is now stable?
Yeah, it's about 1.7, 1.8.
1.7.
Yeah.
And he didn't get transplanted?
He did not.
Okay. And was there any other reasons why he didn't get transplanted?
Well, 79, cardiomyopathy.
Oh, the bed hurt, did it? Okay. And he doesn't have amyloidosis?
As far as we know, no.
Okay. So, yeah, I think that the fortunate thing is that he hasn't seen a daratumumab-based regimen yet. And, daratumumab is now ubiquitous in myeloma, thank goodness. It's the antibody that is directed towards CD38 and gets your immune system that otherwise wasn't very active against the myeloma to direct towards the myeloma. Plus, the daratumumab has activity just by itself in killing myeloma cells. And so very potent, drug for myeloma. Originally developed for relapsed myeloma. Subsequently, now we use it up front, which is why I asked about it in the upfront setting. So I think one drug is daratumumab. The second, one sort of paradigm in myeloma land is combination. That every time we combine drugs with myeloma, we increase the efficacy of those drugs. And so with a stable baseline creatinine, to add on a IMiD drug, and so Pomalyst. So my thought would be Pomalyst and daratumumab. Of course, maybe he could squeeze into a clinical trial with the creatinine being 2. Yeah. And is his heart disease. And hopefully, one thing that we're really examining, I think, and a very important point is that when, the fact that I can guess what would be required for a clinical trial is bad, because each clinical trial should be written unique for the individual patients that you're striving for. So, let's, for instance, daratumumab. When the original daratumumab trials came out, it had the usual creatinine cutoffs of like 2, a absolute neutrophil count of like, I'm sure, 1.5. Do these drugs actually have any impact in creatinine or neutrophil count? Not very much. But what did we do when we wrote those trials is that we cut and paste, and I've done this. I was guilty of this last year. I was writing a trial and I literally just cut and paste the requirements from a previous clinical trial that I wrote. And then I caught myself. And I said, what am I doing cut and pasting from clinical trials? And really, my drug does not require that. And I asked Nicole Gromley at the FDA, I said, do you really care? I mean, do you, if a drug doesn't have any impact on creatinine, do you really care if I put that in there? She said, you guys always cut and paste the stuff, but it really doesn't matter. And so it's not a safety issue. If the drug has nothing to do with kidney function, you don't need to include it. We're not impressed when you do that. Oh, he's so smart because he included it. We're more like, he's so dumb because he included it, because it's nothing to do with that. And so I think that the future of what we need to do with clinical trials is to broaden. So this patient would be, I would love this patient on the clinical trial. And if we broaden our requirements for those clinical trials, we could put them on a clinical trial. But outside of being unable to put them on a clinical trial, I would say Pomalyst. And then I know he's 79, but really maybe transplant, maybe.
Well, that's a couple of things that this person I think it's important to look at a couple of additional points about this case. And one was this patient came in before I saw him with some back pain at the time of his relapse. And here on the left, you can kind of look at an X-ray that shows you not much of anything. This patient has maybe a little bit of dipping right here in the vertebral body, but it looks fine. So the patient had pretty significant back pain. So we got an MRI the next day. The entire sacral vertebral body is out because there's a big spot of myeloma. If you look over here and you never ordered that test, you wouldn't have seen that. And this particular individual, this explained his pain, and it made us really, okay, we're going to probably not just change chemotherapy, but we're going to have to do a little radiation to alleviate some of that. So the other thing that happened with this particular individual, and this is also something that I know my colleagues here know very well, sometimes when people's myeloma comes back, the amount of protein they make, it's different. And so in this particular individual, this is from a study, but you might make a lot of what we call M protein that you might be familiar with, but sometimes when people's myeloma comes back, and this is just one representative case, at the time they were diagnosed, the blue line shows you they had a very high M protein, but almost nothing. But at the time they relapsed, only the light chains are going up. And there's a term we use for that called light chain escape, but it's something that, again, if you're coming in and you're having symptoms, that you really want to make sure that the providers are looking at those other things that might happen and not miss anything. Okay, so going to go to another case here. I'll let Ataya jump in there. So this is another person that I have seen, 71, who comes to me because they feels fine, very fit, but went to have an annual physical. They drew some labs and they said, boy, your total protein is quite high. Patient didn't have any symptoms at all. And you can see they had the labs there. They have a little tiny bit of elevation of creatinine. Their M protein, which I think I forgot to write down, was 2.7 grams per deciliter. You can see the light chains. The ratio is high at 60. 40% plasma cells. Translocation 1114 has a PET CT. What should you tell this individual? And you know what this case represents, if you'd like to tell everybody?
So, most of the times patients come to us for diagnosis of myeloma because they have symptoms, right? They're symptomatic. And think about the first case, kidney failure, health issues. But more now that we have patients having routine physical exam, something will catch the doctor's eyes, in this case, elevated blood protein. This patient felt fine, probably really didn't see this coming at all. But now we're identifying problem early. So the biggest issue in patients with plasma cell problem, like in this case, is trying to figure out, are we at the point in time where patients have enough symptoms, enough disease burden that if we don't do something, they're going to get into trouble, or whether we're actually on the other camp yet where letting things declare itself over time would still be a possibility. So this group of patients are potentially having not yet symptomatic disease, and that's a group that we call smoldering multiple myeloma. There's another group even that have even less abnormal protein, even less number of abnormal cancer cells inside their bone marrow, and that's monoclonal gammopathy of undetermined significance, or MGUS. So this is really all continuum, and Dr. Callender is giving me a case that as we dissect through, the blood counts are perfectly fine. The kidney function maybe a little bit on the edge of normal versus abnormal, but that's still overall relatively normal. What was really driven all of this work up is the abnormal protein itself. And whenever we talk about the M protein, we always talk about the protein that the cancer cells make, and it has its signature. So in this case, it is an immunoglobulin G, and you can tell that it's a lambda subtype because we all should make equal amount of lambda and kappa light chain. And if you have a dominant increase, and that correspond to the cancer cells that are showing up in the bone marrow, that all fits together. We are saying that this is abnormal protein we see in the blood that comes from the bone marrow kind of malignant cells that are now expanding. But this patient really didn't have any other symptoms. The bones were fine. So they are fitting with the so-called smoldering multiple myeloma. They are the rare breed, but yet they're probably the group of patients that we struggle with the most because they're not having such little disease that we could say, we're going to grow old together and I'll probably get to retire and pass the patient on to my younger colleagues. Or whether there were going to actually be this group of people who could potentially progress. So we actually split this smoldering myeloma even further to be the so-called high risk and low risk. Clinical trials for high risk particularly may be suggesting possible benefit of starting treatment early. However, I'm just going to say that statistically speaking, though, this is still a group of patients, a good number of them may not even progress, even if we may help improving the long-term outcomes of someone. We may also be over-treating some. And if you could participate in clinical trial, please do. This is really what we are hoping to be able to clarify further, right, who need to be treated. In my practice, I actually don't treat this kind of patient, but I observe them very closely. I know their starting point, and if they were trying to edge up on their light chain number or their M protein, that's actually when I may talk more about, well, a sign of progression and possibility of getting treated.
I tell you, I'll be honest. I'm all about the drama. I watch reality TV because I'm just about the drama. And I was hoping I was gonna hope we had some drama today, because there's no other. What I think is very interesting is that there's no other dividing point is myeloma doctors talking about smoldering myeloma, because people interpret the data a bit differently. Some people are treaters, some people aren't treaters. I think most of the folks that I surround myself with, because I like my personal life to be drama free, are really, I think we need to do better studies to understand smoldering myeloma before we start treating it. And I personally believe that we need to attack myeloma smoldering biology than trying to apply myeloma drugs to smoldering myeloma, because it's a bit different of an animal. And so I'm also a non-treater. I was told by unnamed source that at Mayo's tumor board, they don't present smoldering cases anymore because they fight too much. And I was like, thank goodness, I need to be on that because I love the drama when it doesn't involve me. But I agree. I mean, I think that one thing that you can look for is evolving type smoldering. So, I think that this person using the standard 2220 smoldering risk stratification would have the M protein was what again? 2.7 cell, they would make the 2220, an M protein greater than 2, light chain ratio greater than 20, and bone marrow plasmacytosis greater than 20, which gives you maybe a 50-ish, and an abnormal cytogenetics, which gives you maybe 50% risk of turning into myeloma. But again, I've had patients that have been high risk 2220 that after 5-6 years have never done anything. I've had patients that have been low risk that have turned into myeloma. And I saw a diagram that I use in all my talks of smoldering about how smoldering is kind of a Venn diagram of multiple myeloma and MGUS. That there are patients that have smoldering that have MGUS biology. They just have a whole lot of MGUS, and it's just sitting there kind of percolating along. And there are patients that have smoldering myeloma that have true malignant myeloma biology. That if you put a MGUS smoldering patient, a myeloma cell next to a normal plasma cell, they'll live in happy harmony. You put a myeloma, smoldering myeloma, next to another cell, then they'll duke it out because they have a more malignant biology. And I think the mission for clinical trials in the present is to be able to distinguish those two groups from each other. One way we can do that is the evolving type, that the M protein goes up and up and up, and the anemia gets worse and worse and worse over a 6-month period. Then that can strongly predict that someone is going to actually start to have true myeloma. And if someone has evolving type over time, then I will treat them as if they have true myeloma.
Well, I think this is great because we could certainly have a big fight about this.
Right on. Here we go.
Based on the data that's published, this individual actually has 3 out of 4 high-risk features, which gives them a progression to active myeloma of about 50%. But you didn't mention that's in less than 2 years.
Yes.
So this particular individual, I did what you wanted. So he went on trial. Interestingly, and he got not what Dr. Cole would like, but he got myeloma-directed therapy. So he got daratumumab, lenalidomide, and dexamethasone as part of this trial. And where he is right now, kind of where you would like him to be, looks like now he's back in MGUS. So he's got a very low monoclonal protein, really minimal toxicity, really no problems. But I have to say this is something I am invested in. But I agree with both of you. These guys really should look for a trial whenever possible. And I think we're out of time.